Hey, good morning. My name is Lucas, and I'm the CRNA taking care of Mr. James Smith. Can I get your name? Nice to meet you, Michaela. Mr. James here just got out of surgery. Are you ready to take a report? Awesome. I'll get started. So this is James Smith. He is a 15-year-old otherwise healthy male weighing 54 kilograms. He has a rather unremarkable medical history consisting of only ADHD and recreational marijuana use. He has no prior surgical history. He presented to the hospital yesterday after being struck by a vehicle while riding his bike. He was diagnosed with a closed displaced oblique fracture of the shaft of the left femur. Additional injuries included a concussion, nasal fracture, and several severe knee lacerations. Upon arrival, he was alert and oriented times 4, had stable vital signs, and his trauma workup was clear. So the pediatric surgeon decided to monitor him for the night and proceed with the procedure this morning. Upon arrival to the OR, the patient was first given midazolam 2 milligrams for anxiolysis. I then placed him under general anesthesia using rapid sequence induction of fentanyl 100 micrograms, lidocaine 60 milligrams, propofol 150 milligrams, and rocuronium 50 milligrams. The patient tolerated induction and intubation very well. Anesthesia was maintained with inhaled isoflurane and a mixture of 50% oxygen and 50% room air. Post-induction, he was also given regional anesthesia by performing a femoral nerve block. I performed the nerve block to help reduce any post-operative pain that he may experience. I did it using ultrasound guidance with 9 mils of 0.5% ropivacaine containing 1 to 200,000 ratio epinephrine with 1.8 milligram of dexamethasone added. He has a 7.0 ET tube, 21 centimeters at the teeth. He is currently on 100% oxygen with controlled ventilation. Respiratory therapy has been notified of the patient's vent settings and should already be on their way to set it up. We plan to extubate tomorrow morning. Please consult speech therapy for the patient's post-extubation swallow eval tomorrow. He's got 2 IV lines. One is a 20 gauge to the left AC and the other is an 18 gauge to the right forearm, which was placed intraoperatively. He's also got a right radial art line that we placed intraoperatively. He's got no central lines. He does have a 16 French Foley catheter. He's got no known drug allergies. The only antibiotic he received was cefazolin, 2,000 milligrams IV push before the surgical incision was made. During the procedure, we had sudden difficulty ventilating this patient. He had a rapid drop in O2 sat and his end tidal CO2 dropped from 35 to 21, eventually dropping all the way to 0. He was rapidly declining, so we moved him from mechanical ventilation to manual ventilation. His poor lung compliance and high peak airway pressures made manual ventilation very difficult. His blood pressure also dropped to 60/40 at this time. Not long after this incident, he had 2 episodes of pulseless electrical activity. In the first PEA episode, the EKG showed sinus tachycardia without a corresponding non-invasive blood pressure. The patient was without palpable radial pulses and had a faint carotid pulse. We gave him 1 milligram of epinephrine and got ROSC within 30 seconds. No chest compressions were done. His blood pressure increased to 140/80. A 12-lead EKG that was obtained soon after showed severe ST segment depression. Soon after the first episode, he went to PEA again. He had a flat arterial waveform and his end tidal CO2 tapered back down, but the EKG continued to show sinus tachycardia. We gave him another dose of 1 milligram IV epinephrine and the blood pressure went up to 150/90. We quickly achieved ROSC without chest compressions once again. Since these events occurred without a clear cause, we diagnosed him with suspected fat embolism syndrome. We will try to confirm this diagnosis with the chest CT once he is stabilized in the PICU. The order for the CT has already been placed. The surgery was not completed. The anesthesia and surgical team decided it was best to close his surgical site and transport him to the PICU to be medically stabilized before trying the surgery again in the future. For his intraoperative hypotension, he received a total of 600 micrograms of phenylephrine through 6 separate doses of 100 micrograms. Total, he received 2.5 milligrams of epinephrine. Also, for his hypotension, he received a total of 2 liters lactated ringers, 2 250 ml boluses of 5% albumin, totaling 500 mils, and 2 units of packed red blood cells were administered. He lost approximately 200 mils of blood during the procedure. Currently, I have Mr. James on 4 milligrams an hour of IV midazolam for sedation and 75 micrograms an hour of fentanyl IV for analgesia, which he is tolerating pretty well. Very recently, his art-line blood pressure dropped to 70/40. We just gave him 50 micrograms of epinephrine, which is included in the 2.5 milligram total I previously mentioned. His current vitals are as follows. Blood pressure 131/74, heart rate is 110, respiratory rate is 16, and his temp is 36.9 degrees Celsius. His only abnormal lab value was a drop in hemoglobin from 14 preoperatively to 8.5 during surgery, so we'll have to keep an eye out on that. I've got a few things to let you know about his postoperative care throughout the night. If ortho says it's okay, try to keep his leg elevated to help reduce possible swelling. For his blood pressure, aim to maintain his systolic greater than 90 and be aware of the potential need for fluids or vasoactive drips if hypotension persists, so have some extra pumps available in case you need them quickly. For breakthrough pain, consider talking to the nighttime provider about adding additional analgesics if needed, but you can titrate the fentanyl drip up if necessary. Continue leveraging the femoral nerve block also. For his sedation, we really want him to stay comfortable, so try to keep him at a goal RASS of -1 if possible. Keep him on a continuous bedside EKG monitor. I would also like him on continuous pulse oximetry and arterial line blood pressure monitoring as well. And perform frequent neurochecks due to his FES risk. Do this at least every 4 hours or more frequently if his condition starts to get worse. Try to maintain controlled ventilation. The goal is to titrate the FiO2 down based on oxygenation status. Follow-up ABGs have already been ordered. Please continue to monitor H&H levels and consider additional blood transfusions if anemia persists. Labs such as platelets, troponins, D-dimer, and electrolyte panels have already been ordered also. Given the patient's injuries, please consult PT and OT to assist with his recovery and rehab once his procedure is finally completed. All right, Michaela, that just about sums it all up for Mr. James. Is his room set up and ready for us to bring him down there to the PICU? Awesome. I'll get everything situated on my end and start to head your way as soon as possible. See you soon.